Good morning. Very difficult to follow these incredible speakers. Oh my God. I'm still just absorbing Stacy's stories. So I have to kind of make this transition. I have to use my skills. And Suzanne, who I know well and we've taught many times together. It's just fantastic to hear you talk about this, which I've never heard you talk about before, and to hear again about these butter sculptures in Minnesota. Because you always teach about them, and I've just still never seen one. But you showed a picture. I appreciate it. Thank you. Thank you. Where I grew up in Oregon, it was Rose Festival princesses. It was not the butter queens or whatever they are. I want to thank sort of a heartfelt thanks to a very old friend in the DBT world and in my life is Perry Hoffman, who has not only persisted in developing this organization with a lot of people, some of whom are here, and it's just the beginning of what this organization's going to be able to do, I think. It's just amazing what you've done. And her persistence in pursuing me to speak at one of these, which she's done for 10 years. And I think this is the first one. So I don't know how you did it, but she just doesn't give up, which is really impressive and talented the way she does it, and her colleagues do it. So it's amazing what's happened. And the people who ran the conference and kept persisting in getting me to send in my talk and my title and my slides and everything else. So thank you for persisting. This is Nicole, Emily, everybody who's done this. And a heartfelt thanks to Seth for putting this together over and over again and having the kind of grace and persistence that he has. And just thinking that he's working on a recovery in a medical condition, so really thinking of him and appreciating him. So thank you, Seth. For me, this is a nostalgia attack is happening when I walked in here because in 1972, on July 1st, I sat in this auditorium in my first day as a Yale medical student. And so here I am again. It was just amazing to walk back in here and see the campus and be back in this room, which I haven't been in for 30-some years. And so it's really cool for me to be able to speak here and to have a bunch of friends here from different parts of my personal and work life. And I wanted to tell, I got caught in this little nostalgia loop here, and I realized as I was thinking that my roots of being a DBT therapist and teacher really went back way before DBT. And by telling a brief story, I think you sort of capture, for those of you who are learning about DBT, might capture sort of what might be in it that would be appealing to somebody who actually was originally trained psychoanalytically, me. I was at Yale Medical School. And by the end of Yale Medical School, I was thinking I wanted to be a psychiatrist and a psychotherapist. And I went into psychoanalytic treatment and training. And it was so weird to go into psychoanalysis. It was the only time I set up an appointment at the beginning of my last year of medical school. I interviewed psychoanalysts. I picked one that I would work with as part of also my psychoanalytic training, also personal psychoanalysis. And we agreed on a date a year and a half in the future at 6:15 in the morning. And we never spoke again until that day. And I showed up and he showed up. But wow, this was like never anything like this. So that was the beginning of my psychoanalysis. While I was in psychoanalysis, maybe 1 or 2 years in, I was talking with him about the fact that when I was a little kid, I was the slowest runner in my class. And when we ran across the gym floor in 3rd grade in my little school, little town, not quite as small as Stacy's town, but almost. I was the last to finish. I was even behind Holly Sparkman, who was tall and gangly, and I thought, and she and I were like considered a pair. Like, here's the slow kids, and it was no problem if you weren't thinking of becoming a professional athlete, but I was. I was already thinking. I wanted to be. I admired Bill Bradley, Larry Bird. I was going to be the next slow white guy that would play in the NBA, and I. By the time I was in 4th grade, I was a gym rat. I knew every gym in town. That's where I spent all my spare time, was playing basketball, and just pushing for that, and trying to get faster. And I worked at it. And at a certain key moment in 7th grade, my father, I can't believe he did it when I think back on it, but he took me for a Saturday appointment to the track coach at University of Oregon, who was a famous track coach for milers and quarter milers. There's Bill Bowerman. And this guy watched me run and gave me a prescription of what I should do over the next year to get faster and to jump higher, because I actually had the rest of the game was developing pretty well. I certainly had the passion. So for the next year, every day, I'd get up early before school and I'd go out to the track, which was right next to my house because I was next to a school, and I'd run the 440, and I would hop on one foot around the 440, hop on the other foot around the 440, hop on both feet around the 440, run wind sprints, and then finish off with a bunch of 440s. Then at night, I would jump rope for an hour. And I just devoted. And within about 2 years, I had the strongest legs you ever saw, and I was no faster. It's like, you realize, the coach didn't grasp the difference in physiology between the neuromuscular junctions, which were genetically programmed to never fire very quick, and strength, which is a different thing. So I had really strong, slow legs, and I was no faster. And by the time I was about 16, and I was not a starter on the varsity at my high school, I thought it really was a dream that died very painfully as I realized this is not happening. And so I'm telling my psychoanalyst about all this, telling him the story. And as he sat there behind me, as I was laying on the couch at 6:15 in the morning, and at a certain point I said, and I'm still so slow. I go out, I run around the track at Yale, the Yale Bowl, it's called, where all the athletic fields are. I would go out there every afternoon, every evening. I would do, whenever I got time, I would go be running. And then I would run in these community races for 1 mile or 5 miles or something like that, and I was always kind of slow. So I started talking to him about, I've worked so hard at this, and it's never changed, and it was such a crushing blow when I was 16. And, I don't know what to do, and I was 31 years old at that point. And at a certain point, he said, after not saying anything for a while, which actually I found very helpful, because most people around me talk too much. And he said, but what makes you think you're so slow? And I thought, did I hear that right? I said, because I am slow, I said, because I am slow. Because I run the 440 in such and such, the mile in such and such, the 100-yard dash in such and such. For somebody who has spent this amount of time and who wanted to be a professional athlete, I'm incredibly slow. Do you understand that? Long pause. But what makes you think you're so slow? I thought, oh my God, did I not make this clear? And I said, have you never been on an athletic field? Have you never been to an athletic event? And I started to demean him for how short he was, and he was round, and he smoked cigarettes. And I thought, this is the wrong psychoanalyst for me. I need a sort of a small-town Oregon guy, not a New York Jewish guy who's going to never get this. And so I was really upset. And then I said it again. I said, let me make myself perfectly clear. If you run the 100-yard dash in 18 seconds after you've devoted thousands of hours to it, that's really slow. What did he say after a pause? What makes you think you are so slow? He really did. It's just a real story. He's dead now, so I could say whatever I want, but it's actually true. He was down the street from here. And so I thought, did this man have a stroke? Was this what you call perseveration? It's like keep saying this and think. And so I stopped talking about it. But what did I do? I actually, in my running at the Yale Bowl, I saw this guy there who I had seen there a lot. He was a Yale athlete. He was a track athlete. He went out there, he was like a serious track athlete. You knew this guy's serious. He showed up with sunglasses on, and he would take them off, and he would put everything in a pile, and he had a whole routine, and he'd work out. And I thought, this guy knows what he's doing. And I went to him, and I said, would you watch me run and tell me if there's anything I can do about it to get faster? This guy takes me under his wing. It was like just a perfect moment. I mean, this guy apparently was looking for somebody to mentor. And so he watches me run, and he acted very non-judgmental. God knows what he told his friends, but he'd say, no, there's several things you can do. First of all, you're running like a very tall goose. You know, like, and and you just, you know, that it's somehow you got in your head that that's how you run, that you stay standing up, you lean back, you take long strides, and you look all over the place. This is like exactly wrong. You have to lean forward to the point that you actually think you might fall down if you don't take the next step. You have to look straight ahead and never to the side. You have to take short, choppy steps that as a tall person, you need to know that you have to take steps that feel way too short and way too fast. And you have to think of where you're going and how to get there. In other words, seriously, he gave me very specific, he sort of did skills training for somebody like me to try to run. And then he watched me, and then he coached me, and then he saw me the next day. And within 2 months of working with him, I dramatically changed my times. It was like totally memorable. I mean, a turning point for me to think that you can change something this refractory in such a short time if you do it the right way. If you have this combination of somebody who motivates you, which is what I would say my psychoanalyst actually was a brilliant motivator. Maybe that wasn't his point. I mean, his point was he was focused on intrapsychic life. He was focused on how I experienced myself. And actually his question of what makes you think you're so slow, it could have been what makes you think you're so slow, or it could have been what makes you think you're so slow, or what makes you think you're so slow, or whatever. In other words, he was like trying to penetrate my rigid wall of belief that I couldn't be any faster, and my parents gave me the wrong neuromuscular junctions, and they were to blame, and there was nothing to be done about it, and it ruined my life. I mean, he was like listening. He was actually listening. I valued it enormously. It may sound like I'm making fun of a psychoanalyst, but actually it was brilliant. It was brilliant. And it got me, it penetrated my wall of belief that I could not perform. And after that, I met the other guy in the treatment, the skills trainer. So I had a psychoanalyst and a skills trainer in the same treatment. They didn't know each other. They didn't care about each other. They were totally pursuing different goals. One actually wanted me to run faster, and the other one was trying to sort of penetrate through the way I thought about myself. And actually, I got fast enough, believe this, if you know any times, in a mile run in New Haven, 2-3 months later, I ran a mile in 5:35, which is the fastest I ever did, which was unbelievable to me. Never could I have imagined doing that. I was 32 or 33 then. I thought, Larry Bird retired at 33. I mean, maybe there's still a chance. I still can, the end of my potential career, but I didn't pursue it. Instead, I went into something that requires no speed at all, which is psychiatry. And so I still, right up to last night, continue to watch and admire and envy some of these athletes. But, I try to do my own thing my own way. Now, that's DBT before DBT was constructed. Linehan was constructing it during those very years, actually. But what is that? What is DBT there? It is that it's a treatment that attends to your capabilities, which means how do you do things effectively if you know what you're trying to do? How do you get there? How do you get from here to there? And it attends to your motivation. It's like your thinking, your emotions, everything that's getting in your way so that you can't even think that you can get there. It's supposed to attend to motivation and capability. And I didn't realize that at the time, but that was such a formative experience for me to think back on that whole thing that I thought, this is not a very interesting thing for a clinician to treat compared to things where people are ruining their lives. But it was sort of a model for it for me. The next thing I want to tell you very briefly, because then I want to cover some slides. My point today is going to be to sort of try to get the essence of DBT across and then rapidly go through the progress in DBT since it began and talk about where we're at, where the trends are, and where I think it's going, some of the things that are going along now. You just think. Now, I think it's actually, given the time, I should probably just jump ahead and then if I get a few minutes, I'll come back. There's the story of how I went from running a psychoanalytic inpatient unit with Otto Kernberg as my mentor to discovering DBT and then moving on and trying out DBT and ending up thinking I would do it for 2 or 3 years. And then here it is, 25 years later. Having written an article then about the difference between Kernberg and Linehan's models. So in 1989, it was published, really trying to figure out the differences of these things. I'm at a different place now, as Lois Choi Kane could tell you. She's a presenter this afternoon. She and I finished an article recently looking at mentalization and DBT. And so I'm always interested in the ingredients of different models that actually help people move forward rather than getting stuck in any one package. Though today, now back into my package, DBT. Let me go over some slides. See if I can do this as well as Suzanne Witterholt, the technological genius of... Thank you, John. You're welcome. In the beginning, meaning the 1980s, DBT was an outpatient treatment for parasuicidal behaviors, and that's been discussed for women with borderline personality disorder. What was it at that point in time? Just to lay it out as simply as possible, it was that the patient, there were 4 things that went on every week. There was individual therapy every week. There was skills training every week for the patients. There was a telephone consultation whenever needed, which was calling the therapist and getting coaching in the moment to use skills when facing difficult situations. And there was the therapists getting together every week and supporting each other and trying to stay adherent and stay on track and keep learning the treatment, support each other in the treatment. There was a list of treatment targets that Suzanne went over earlier, sort of prioritized, so that if you started out with all those pieces of, in her nice picture there, you figure out which ones to prioritize over which others so that you go step by step. So it's not only a dual diagnosis, it's a trio diagnosis, it's a multiple diagnosis treatment. So that the patients that in my work, for which for many years has been to be medical director of the Department of Mental Health in Western and Central Massachusetts and oversee the clinical system there in the public sector, where if somebody's highly suicidal and they have a substance abuse problem, they can't get into a substance abuse program because they're suicidal, and they can't get into a suicide treatment program because they're still actively using. And so it's like this standard problem that DBT is a multiple, yes, you're substance abusing, you're doing this, it's all in the same treatment, but we have to do it in order of priority. There are certain standard agreements, certain standard assumptions. There's a protocol for how to manage and assess suicidal crises. And there's 3 basic sets of strategies: problem-solving strategies that are based on cognitive behavioral therapy, validation and acceptance strategies that at their deepest probably are based on mindfulness and various sources of mindfulness, including Zen, and dialectical philosophy as brought to life in treatment in a way that, again, I think Suzanne nicely explained. The total focus of that therapy from the beginning was that the therapist focused relentlessly, persistently, on reducing high-risk behaviors in a way that Stacy, I think, nicely captured when she was saying what she heard from her DBT therapist of what was expected. Yes, you can do this. Reminds me of kids playing hockey, And there was a professional wrestler that was the father of the goalie on my older son's hockey team in high school. And I would stand there next to this guy who had the mohawk and he had tattoos and he was like really like big time professional wrestler. He'd stand there and like this. And his son, as goalie, if his son ever looked like he wasn't going to get up after a terrible hit, he would yell out to him and say, "You have a broken neck? Somebody break your spine? Any other reason to stay down?" It's like, I mean, he had that quality, but he didn't have that compassion part, that was the other part. So just he had a piece of it, but he needed to go through another lifetime, I think, to sort of put it together. So it turned out that was the package, by the way. Realize the package was very specific in those days. It was treatment for women. Treatment for women with suicidal behavior, treatment for women with suicidal behavior and other features of borderline personality disorder. And it was a treatment of an outpatient clinic, and it was a once-a-week psychotherapy, and it was a certain this, and this. In other words, it was very specified. So anything you did outside of that wasn't the package. It was experimental in those days. So that was, late 1980s. Actually, the first manual I got from Linehan is when I started doing DBT on an inpatient unit. And she sent me her, quote, manual in 1987, which was from 1984. And it was just a pile of papers. And it was hard to even talk with her about when I wanted to talk with her about a certain thing in there because I'd talk to her on the phone and say, "Marcia, this thing that you call radical acceptance, really what is this? I mean, how do you really get this across?" And in those days, she was doing the only DBT in the world. It was not outside of her lab. Actually, the program I developed in White Plains was the first DBT application outside of her lab in the world. And so she loved the doctor from New York is talking to her. So she'd be on the phone anytime I wanted. And I'd say, "Marcia, this radical," she'd say, "Which page is that on?" And it turned out every page was page 1. So it was, she would find it though and we would talk. And so that was the first manual, was the 1984 unpublished thing, which was way bigger than the manual that came later in 1993. And so in those days, it was a manualized, very specific treatment. It didn't have other things that you did. It didn't have other patient populations. So that's part of where things have changed so dramatically. And what did it do, that package? Well, it did these things in the first studies. The first published study in 1991 in the Archives of General Psychiatry, which was kind of amazing to have a female psychologist publish a psychotherapy study in the Archives of General Psychiatry. She was turned down 3 times, and she just knew that's where it had to be because she had a sense of this has to get out there in the world. As most of you probably know, her own mission from the time she was 19 or 20 years old had become how to go back in and get other people out of hell. So she's like pushing for that. So she gets it in the archives. She publishes this. She has follow-up studies. She shows that actually compared to treatment as usual, you can do all of these things, which are standard things, have been discussed many times. I just want you to notice at the bottom that misery remained. That was one of the interesting findings of her studies, is all these dramatic behavioral changes, but people were still often reporting as much depression, as much anxiety, and as much hopelessness. Over the past 20 years, these findings have been replicated more than a dozen times, actually more than 18 times as we speak right now, in randomized controlled trials that just keep showing this package works, this package works, this package works. In those studies, we learned very important other things that aren't usually the first stated findings. They include the following. What you choose to target matters. In other words, if you're doing DBT, but it's a DBT for suicidal behavior, you're just not really specially focusing on substance abuse, don't expect it to get better. Same with eating disorders. That actually it matters. If you include something like substance abuse or eating disorders in your program, chances are you're going to figure out how to improve it. So that this is an important finding, I think, in any treatment. Actually, Hilda Bruch found this as a psychoanalytic therapist for eating disorders, is that she noticed other psychoanalysts doing standard psychoanalysis, trying to look at the underpinnings of eating disorders, and she added in a component where you actually focus directly on the behavior of an eating disorder, and she started to get good findings. And I just think it's something to keep in mind. Adherence to the manual matters, at least in DBT, and I think every treatment needs to study this, about whether it actually matters if you're adherent to the treatment. And adherence is hard to define, but Linehan has worked her butt off to try to define it. It's just really, really a complicated treatment. Validation matters. It matters more than Linehan first thought it would. I think it's fair to say this. I used to teach a lot with her and train with her at the beginning, and her idea at the beginning was more that validation is the sugar coating. This was her metaphor. Because the bitter pill of cognitive behavioral therapy is often hard to swallow. But that's the change ingredient. So you need validation, enough validation in order to get the medicine to go down, in order to get somebody to participate in problem solving in their lives. Actually, it turns out over these subsequent years, validation in its own right, now there's much more research on that, and validation in its own right is a change agent. It is a change agent. It helps people emotionally regulate, probably better than almost any other single strategy that we've got in DBT. DBT reduces the overall cost of treatment, which is a little paradoxical to insurance companies because actually up front it costs a little more than what they're usually paying for. But if they look over a period of a year of people who have suicidal behavior, they're going to save money generally, because of the reduction in hospitalization. Reducing high-risk behaviors doesn't necessarily reduce misery or longer-term life dysfunction. This has been seen in study after study and in Mary Zanarini's work following at McLean Hospital, following the longer term, that you get better in some ways and then not better in other ways, and that leaves the field groping with what to do about the remaining axis 1 disorders after behavior's under control, or the remaining misery, and some of the other targets that you go after in stage 2 of DBT, which is now a big focus. DBT improves some comorbid disorders better than others, so that you can typically reduce depression, substance abuse, eating disorders if you're targeting these things. But it's not unusual for high levels of anxiety and PTSD to remain after you've solved other problems in your life. So that's just an important thing, because then you really have to up the ante a little bit on treating anxiety disorders and PTSD. Meanwhile, DBT's biosocial theory, and in the interest of time, I won't be able to go over that here, but in a nutshell, you heard a little about it this morning, which is that it's the theory that says that if you have a fair amount of emotional intensity or sensitivity or reactivity, and you grow up in an environment that doesn't validate that and invalidates that, that actually you get stuck in a trap. The trap of continuing to have those emotional responses, cognitive responses, and being in a situation where pervasively there's no one around you that's validating that and saying, well, of course you feel that way. And yes, let's figure out what to do about it. In other words, if there's a big mismatch, you get stuck in this trap that becomes almost like its own hell that continues and perpetuates and can get worse over time if you don't get that validation and effective treatment. So that meanwhile, the biosocial theory has been increasingly under study physiologically and subjectively for years now, and just it looks like most elements of the theory are getting validated. But I won't go more into that. That's sort of where we're at as a field right now, is that this theory that was put together in the 80s by Linehan turns out to have been a pretty good rough way to start, and the specifics are getting clearer. Recent trends in DBT. This is kind of a table of contents of the next few minutes of this talk. So this is like a header slide. One thing is the extraordinary extension of DBT in the world. I mean, I wrote a commentary in a publication about 15 years ago about what makes DBT so popular. Because actually, it started being popular before the data came out. And then even when there was only one study, it started to be treated as if something that had 15 studies behind it. It was like amazing to me, as somebody who came from another very challenging amazing and esteemed treatment, which was Kernberg's work, to go out and teach a DBT workshop in the Upper Peninsula of Michigan and meet up with somebody who's a graduate student of Marshall Linehan, and 400 goddamn people show up. It's like we flew over trees. That's all we saw. I thought, nobody had heard of DBT. I thought, who's going to show up to a DBT workshop in Bismarck or Port Huron or whatever it was? And, well, 400 people are there. I thought, wow. And I talked from a lot of clinical experience, and the graduate student talked from a lot of teaching and one patient. And everybody was like knocked out, and I thought, what is this? This is like a hoax that everybody's getting. Now it's like the best, it's the only hoax in the world with 18 randomized controlled trials behind it, I think. But oh my God, the dissemination, the interest in it went beyond the data. And in the thing I wrote then, I thought, as I really sort of took stock of what seemed to be that people found so gripping about this treatment, was first of all, we had an unsolved problem that caused an enormous amount of suffering. Patients, clinicians, families, communities, hospital administrators. It was like, this was not solved. Secondly, in the era that we're in, to put together a treatment that includes evidence-based practices from behavioral treatments to really change behavior, along with studies of emotion regulation in the brain, along with mindfulness practices that most people at that point thought, oh yeah, I remember when I practiced transcendental meditation or did yoga, but like to take that seriously and integrate that into a treatment, and to take seriously the invalidating environment and studies on trauma and the treatment of trauma, and put that all in the same package and add into it support for the therapist so that they can keep giving support to the patient, was like, I just thought people were very captivated by this, and then the data started coming out and just, I think, has kept it going. Increased focus on emotion dysregulation, topic number 2 here, big trend, is that even though that's been part of the theory from the beginning, is that you have emotion dysregulation is at the core of the disorder from a DBT therapist's point of view, is that you're seeing the emotion dysregulation coming about because of a sort of a sensitive, emotionally dysregulated nervous system to begin with, and an invalidating environment. You end up with chronic, severe emotion dysregulation, and that is the infrastructure for the rest of the problems that come up. That was always part of the theory, but actually, in the last 5 years, the focus on the treatment of emotion dysregulation has gone more and more in center stage, and now with more data behind it, so that actually we find that DBT, and in particular certain aspects of skills training, reduce emotion dysregulation now that it's a construct that's increasingly measurable. And if you can decrease emotion dysregulation, it's turning out that you can decrease the high-risk behaviors that go with it, of course. So the increased focus on emotion dysregulation and linkages with studies by biologists, neurobiologists of emotion dysregulation is just like something that's a strong trend in DBT. If you go to any DBT conference where new stuff's being presented, everything's starting to get framed in that way, getting studied that way. So that's a big trend. Efficacy of skills only. DBT is a package, right? After being validated as a whole package many, many times, of course, the next research step is to figure out what it is in that package that actually is helpful. What are the active ingredients in this complex package? If you can figure out what the active ingredients are, the core components, as implementation specialists call them, if you can figure out the core components, you can probably develop a more efficient treatment. You can probably narrow down on the things that seem to have the most bang for the buck and really go for it. So, DBT is still at, in a sense, an early stage of dismantling studies to figure out which elements of this treatment actually are needed, are actually the strongest, and is there a better way to put them together. So coming out of that right now, and there have been several different types of dismantling studies, I think most surprising finding to Linehan, she gave a talk in November at the ABCT meetings, Association for Behavior and Cognitive Therapy, where she was asked on stage, one of these big things with 1,000 or so people, what do you think in your 40 years of doing this work has been the biggest surprise in your career? And she said, the biggest surprise is recently, the last 10 years, starting to see that skill packages that are mainly skills training are way more effective than I thought they would be. I thought you needed the whole package: individual therapy, skills training, all the coaching, the teams and everything. And now, actually, there's several studies out that focus more on the delivery of skills, along with some of the aspects of DBT, but not everything, that are turning out to be pretty effective. So those are, I'll get back to this. The next one is the potency of validation as a treatment tool, and also the potency of invalidation as a destructive force. There have been just more and more studies, and I think that trend is continuing. And finally, the increased focus on PTSD within DBT and how to treat that. It's always been there, but actually there hasn't been a model for it until recently, and now I think that model is just gaining legs more and more, and I think we're going to see more and more of that. Now, to cover some of these in more detail. That wasn't my last slide, was it? No. Oh, all right. Is that the next, or did I go too far? There. Dissemination. This is how my computer at home works. You click, and then you tune in tomorrow. Okay, I think it's going to go past that because I clicked again. We'll see. Dissemination of DBT, I already said some things about it, but just a few things about it. 25 years of dissemination continues around the world. I'm just stunned by it myself. I do training in other places. I currently am overseeing an implementation in northern Italy. I'm overseeing an implementation in the western part of Sweden, places where there hasn't been almost any DBT, and people are just as excited as anybody's ever been about it, and there's much more to bring to them. I'm in the middle of an implementation with Kaiser Permanente Foundation in the mid-Atlantic states, where we're doing Virginia, Maryland, and DC, and they're doing a mainly skills-only model throughout Kaiser there, and they're really doing it well, and they're getting really good training. I mean, so it just keeps going, which has been quite amazing. I was once having lunch with David Barlow, who, as many of you know, is sort of one of the deans of psychology in the world and of anxiety disorders treatment, and we were at a conference like this, we were having lunch, and he said, it's like 10 years ago, he said, "Could you tell me something? Why is it that I've developed a treatment that has 35 randomized controlled trials, it works every time, it's fantastic, it changes people's lives, and it isn't anywhere out there? And DBT that has 5 goddamn studies is everywhere, every county in the United States has DBT. What is this?" So there is something very interesting. I was called to Austin Riggs Hospital a few years ago to spend a whole day consulting with them about what is DBT, but also I thought the underlying agenda was to find out for me, how did we market it so effectively? We've gotten smarter about implementation. I've done a lot of implementation. So we've gotten smarter to figure out how to really make a high-quality implementation happen. And also, we've seen more and more hazards of widespread implementation. It went way ahead of the data. It went way ahead of good training techniques. So people are out there doing what they think is DBT, they call DBT, and then it doesn't work. And then it means DBT doesn't work. And the whole world of serious DBT implementers are just suffering with finding out how much DBT is claimed to be going on, but if you watch it, it's not DBT. So this has been a big problem of success. BPD advocacy has grown more influential. This organization, NEA BPD, has just been incredible in beginning and continuing advocacy. The fact that NAMI embraced borderline personality disorder as a biologically based condition that they support, which also was from advocacy groups like NEA BPD, also TERA is another advocacy organization, and a lot of individual consumers and family members that have just pushed and pushed and pushed to try to get this acknowledged so that there could be funding for this. I think the influential of advocacy groups, the influence has just been huge. Training options and vehicles have proliferated, and just rapidly the computerization of training, figuring out how that fits in with in-person training, figuring out how to put it on smartphones, applications of DBT, of which there's now several. And then this new journal that also is co-sponsored by NEA BPD that's really just coming out, and everybody should tune into this, pay attention to this, and get it, because the people running it, I mean, the people who are the editorial board with Martin Bohus and John Oldham and Schmal from Germany. This is going to be a fantastic journal that brings together not just DBT, but issues about emotion dysregulation and borderline personality disorder. So keep your eye out for that. It's now, coming. Adaptations about target behaviors, other things that have happened in DBT, and just seeing Emily walk this way, it's like, I've got PTSD already. It's like, I have 4 minutes. So the original target was parasuicidal behaviors, but where are we today, 25 years later, essentially? Well, now there's a substantial evidence base for the treatment of substance abuse. There's a substantial evidence base for the treatment of binge eating and purging behaviors, and both of these along with borderline personality disorder. There's a preliminary evidence base for treating cynicism, depression, and rigidity in people who are older, who have a depression and they're just, they're not doing the things that would help make them better. Turns out that in preliminary studies that DBT skills training was helpful for them. PTSD within the borderline spectrum. There's preliminary evidence that I'll get back to that actually we can really start to change that. Bipolar disorder, there's preliminary evidence that the applications of DBT modified for bipolar actually can be helpful. ADHD in adolescents and adults. There's a lot of, always people have cited the overlap between ADHD symptomatology and borderline symptomatology, and they're often traveling together, and when you start to look more and more at teenagers and younger kids, you really see this happening. And so, applying DBT to try to reduce the symptomatology of ADHD, it turns out that there is preliminary evidence that that is helpful. Also, oppositional defiant disorder in teenagers, and also anorexia nervosa has never really been a target so much of DBT, which has really been more of a focusing on behaviors of discontrol, out of control. But it's been a little bit of a stretch to apply it to disorders of over-control, restricting eating, as opposed to losing control of your eating. So now, though, there is an application by one of the DBT researcher, Tom Lynch, out there that's starting to look like, okay, there's a little bit of pilot evidence that this may turn out to be helpful, this sort of DBT for disorders of over-control. And it's, at least for now, the book isn't out yet. I'm actually reviewing the book, but the provisional title is Radically Open DBT. And I don't know if it'll keep being called that. Adaptations other than target behaviors are going to be arriving on your local screen at any moment, because I clicked this a while ago. There it is. Populations, a theater near you will have this. So in addition, where else has DBT been being adapted? It's being adapted to adolescents with suicidal behaviors. And while there was pilot evidence, it's now traveled all over the world. People are doing it without much evidence. But now there's 2 major multi-site studies that are generating evidence, one on the west coast of the United States and one in Norway, where actually the data is looking really good for treating suicidal and impulsive adolescents. Families with members diagnosed with BPD, so that you have the family connections work that's been supported, that's been part of NEA BPD's mission, and Alan Frazzetti's mission has been helping people. Also, populations like couples with domestic abuse, again, Alan Frazzetti's work with that population of people, both the abusers and the victims, how emotion dysregulation plays a role in the family system, and how addressing that might reduce domestic violence. Juvenile offenders in residential settings, there's several applications. Pre-adolescent children now, and Paraplechikova, who I think is here, right? Francesca is here, right there. Yeah, is sort of taking the lead in this really interesting modifications of DBT to apply to pre-adolescent kids. And there's some literature out on it. There's a grant underway, right? 2 grants underway. So, pardon? One at NIH. And I've seen other applications for children that are really interesting, but now it's being studied right here. Intellectual disabilities. the application to cognitive impairments, intellectual disabilities that Julie Brown has done, and I think she presented that actually at a previous NEA BPD meeting, didn't she, Perry? Yeah. Caregivers for partners of individuals with dementia. There's a DBT application somebody's done with that group, and teens with poor compliance to medical protocols, one of the most touching studies you'll ever hear about, if you haven't heard. How many of you know about this study from New York about kids that keep getting bumped off the list to get kidney transplants? You don't know about this? It's published. It was a series of 6 kids, but this is what in the group that works with Alec Miller. Kids that are in the hospital that have kidney failure and they're on dialysis, and they get bumped off the list for kidney because of their behavioral issues. You have to meet certain criteria of compliance and staying on the list. So the application of DBT in an 8 or 12-week application with these kids got 6 out of 6 kids to be able to be back on the list and get kidney transplants. It's like, oh my God. So the application of DBT within medical non-compliance, I think, is the broader issue. And now you are really serious over there. I see you there. And final one I'll mention here, and then I'm going to stop and take questions. I think I have more slides, but what the hell, they're just slides. Is public sector clients, which have been a passion of and a centerpiece of my work, people who get stuck in the mental health system and can't even think that they could get out of the mental health system. They don't even know how to ask that question because their life has become the mental health system. And Kate Comtois in Washington started taking that in a very systematic, serious way to develop ACES, ACES, accepting the challenge of exiting the system, which is just a brilliant application of DBT to help people go from being embedded in the system to working their way out as a target, as a goal. So really interesting applications. And I'm going to stop there to take questions, and then we do have a panel at the end of the day. I'll also be here for that. So do we have questions?
All right, so please pass your questions to the aisles and we will run them up. You actually touched on something that is a question we have. There are questions about DBT to treat couples. So do you know of any extensions that are not specific to domestic abuse that might be more general?
For what? For working with couples?
Treating couples,
yeah. Yeah. I think here, though, a number of people have done this, and I've done this in my own work because I work with couples and families, so I apply it in various ways. But I think the person who's most systematically been developing this is Alan Frazzetti, who actually wrote a book and published it many years ago called The High Conflict Couple, which is really about how you treat a high conflict couple with using the basic construct of emotion dysregulation as the problem and the use of creating a validating environment as a prerequisite, and how to really focus on that. It's really a great application of DBT, and it's been there for quite a while. So that's where I would suggest you go next.
Excellent. We have a question wondering if the skills-only approach that you were talking about, do you think it could be applied in a prevention focus, maybe taught in schools, churches, other community settings, or do you know of any work on that?
Yeah, and it's a great question, and there is work on that, and there'll be a manual published in a few months on this by Jim Mazza and his wife Liz Dexter Mazza. You can look for that. And for middle school and high school, it is a curriculum and a manual for how to bring it into the schools, both implementation within a school, because that's very challenging. Again, like the thing with children, like the thing with other populations, a lot of people are actually doing it in schools now. In my area in Western Massachusetts, there's quite a number of schools that are now doing more and more DBT skills, either at after-school programs or during lunch, or building it within wellness or health classes. And now there'll be this curriculum that's really well-researched, and this is really going to revolutionize it. So I think there's enormous pull for it, and the idea of prevention goes nicely with other things that came up earlier today. So yes. It's out there. Look for Jim Mazza, M-A-Z-Z-A. I actually think you can already even order the book on Guilford Press, but it isn't out there yet.
Related to that, to the skills-only approach, can you clarify what components of DBT are omitted when you're doing skills only?
I'm so happy you asked this question, whoever that was, because it's one thing to just say skills-only approach, but actually what we've seen so far, and the serious way to do a skills-only approach, which is what we're trying to do at Kaiser in the places I mentioned, and that they've demonstrated to work in Canada and to University of Toronto with Shelley McMain's more recent study, is that you do include the whole package of skills training. You do include that therapists have a team meeting, so the consultation team is still included. You still include coaching in between sessions by telephone, though actually in Shelley McMain's study in Canada, there was very little of that actually went on, even though they were ready to handle it. And still the findings were good. So that actually was mostly skills. And finally, it includes the therapists knowing the suicide crisis protocol to assess, identify, and manage a high suicide risk. If you put that package together, what are you leaving out? You're leaving out individual therapy conducted according to the DBT manual. You might have a different individual therapy, so mainly the thing you're leaving out is the really DBT-based individual therapy.
All right. We're getting some great questions. I don't know if we'll have time to get to all of them, and if so, then we'll definitely bring them up to the panel. What would you do differently for someone who's already in DBT for symptoms of PTSD? Is there something you would do differently?
So somebody enters DBT and they have a lot of dysregulated behaviors, a lot of pain, a lot of sufferings going on, and they're to some degree out of control in their life, and they have PTSD. And that's part of the picture. They're having flashbacks, they're having nightmares, they're having intrusive thoughts, they get caught in these memory traps that they get into, they get triggered into things. So this is not an unusual group within the borderline personality disorder population, right? So what do you do if you know somebody has PTSD from the beginning? Well, I think first of all, you orient the patient that you're going to treat the whole thing, that is central to the treatment, is treating PTSD. Because some people enter DBT and say, you're telling me I just have to learn skills? And no, we're not telling you that. We're telling you you have to learn skills on the way to becoming more resilient, on the way to treating the things that have caused your suffering in your life. And if that's PTSD for you, that's PTSD. So the first important thing is to make it clear. This is within the treatment package. It's a stepwise approach in treatment. It isn't left out. A lot of people bail out of DBT in stage 1 because they actually want to talk about their trauma. And the other thing is that when I work with people that have trauma-based problems, when I'm doing the work in stage 1 of trying to help them get their behavior under control, over and over again, when we look at scripts of behavior, behavioral chain analyses, you find here and there and all over the script, there's evidence of the PTSD. You stop right there, you acknowledge it, you validate it, you label it, you say we're going to treat this, you help with those symptoms right now, but then you try to get the person to the point where you can actually go in more depth and get the whole story in a more comprehensive way within the therapy, which is the treatment of the PTSD along the lines of the current protocol we've got by Melanie Harned from Seattle.
And we have a call-in on that next Sunday. Melanie's going to be...
Oh, Melanie's doing the call-in next Sunday night. Let me just, she's fabulous at this, and she's hybrid. She's created the synthesis between DBT and prolonged exposure treatment for trauma, and she's really put them together in a brilliant way, and now she's gathering data for that. So you should tune into that.
And that's the NEA call-in series that you can find the details out for on the NEA website, which you will also find in the beginning pages of the booklet. Last question for right now, before we take a break for lunch, is that we have a question asking about the effectiveness of DBT for males suffering from BPD. Are you aware of efficacy studies specifically in males?
Well, what's changed from those first studies is that males have been included in most programs and in studies. And so what has been noticed in those studies that have males and females is that actually the males are doing as well as the females. There's also been more recent data just epidemiologically that makes it clearer that whereas we used to think that about 80% of people with borderline personality disorder are females, that actually that's not true. That it's closer to 50-50 than it looked if you include things that usually are sort of male specialties of disorders of over-control, certain impulsive behaviors, antisocial behaviors. But yes, it looks like the data is just as good for males as it is for females.
All right, well, thank you very much, Dr. Swenson.
You're welcome. Thank you.